25 million people in the United States are currently diagnosed with diabetes, which is 8.3% of the population, but that makes up over 25% of hospital admissions. And also 25% of people over the age of 65 are diagnosed with diabetes. Complications from diabetes can be macrovascular, from the thickening of the basement membranes, causing neuropathy, nephropathy, macrovascular from the oxidation and inflammation leading to heart disease, stroke, and then infections from poor tissue perfusion, delayed wound healing. So the Joint Commission and ADA both recommend inpatient diabetes education, specifically for survival skills, to reduce readmissions, and to give them that baseline knowledge until they can get outpatient support. ADA also recommends transition of care education, because in the hospital they recommend insulin as the primary treatment in inpatient treatment, and then transitioning to whatever their outpatient medications are. There's kind of that incongruency. So the facility that I did my project at does not follow the recommended inpatient diabetes standards of care with the transitioning. A lot of times they're not using inpatient insulin, and the facility doesn't currently make any discharge follow-up appointments, which is an ADA recommendation. They don't track medication reconciliation or education for diabetic patients, and then readmissions are also not tracked for this population. So very minimal data collection at the facility on diabetic patients. So the purpose of this project was to follow a structured transition of care program recommended by the ADA, which includes making outpatient follow-up appointments for patients with a hemoglobin A1C of 8.5 or greater, completing a medication reconciliation for all diabetic patients, and providing survival skills education prior to discharge. So conceptual framework, a lot of research is based on the Diabetes model, which is structure, process, and outcome. Structure includes the setting, your facility, who's going to be a part of the program. Process was using the chronic care model, which is how we're transitioning to more of a preventative self-management of diabetes, and then outcomes. And again, the theoretical model basis was the chronic care model, transitioning from inpatient immediate care to self-management. So literature review, again, hospitalizations, diabetics are 8.3% of the population, but 25% of hospitalizations. It's also $245 billion in diabetes care, with over $180 billion being associated directly with medical costs, the remaining with like not being able to work and other funding. Readmission risk factors are age over 65, being recently admitted in the last 90 days, longer length of stay of 8 days or more increase readmission risk by 8 times. Race, specifically African American, and increased risk factors for readmission when they have Medicare or Medicaid or government insurance versus a private insurance. And then patients that are not employed, even the retired and veterans, are at higher risk of readmission. So themes we found related to readmission are lack of literacy, of health literacy, and increased A1C level was related with 180-day readmissions, but not with 90-day readmissions. Not being able to access insulin and not being able to access the healthcare providers. So readmission prevention is basically getting that survival skill education, having access to outpatient, having access to medications. And then again, the barriers is a large amount of access issues. And then patients having a lack of they believe that they don't have self-control over their diabetes. Project objectives, my outcome objectives was to increase diabetes knowledge and to reduce 30-day readmission rates. And to do that, I was going to follow making sure discharge summaries, including a medication reconciliation, are done, discharge follow-up appointments for patients with an A1C of 8.5 or greater, and then following the documentation of patient education. So with the organizational needs, readmissions are not tracked, and the facility doesn't have resources. The larger sister facility has a diabetes coordinator, but there are no diabetes educators in any of the facilities within our healthcare system. And bedside nurses are expected to do all of the diabetic education, which with their time and all of the other things that they are expected to do, that's one more thing on their plate. They're also only given 45 minutes in brand new nurse orientation as far as education on diabetes. So they don't have the education to provide to the patients. And then there's an incongruence between inpatient and outpatient regimens. Again, inpatient, most patients are put on a sliding scale or basal bolus insulin, and then outpatient, they're expected to resume their home medications, but they aren't taught, okay, when to start taking them, what to transition to, what to continue, what to discontinue. So there's a need for patient education, self-management, and survival skills. So this was a translation of evidence with a convenient sample size. My inclusion criteria were adult patients that were admitted for longer than 24 hours with a history of diabetes. At this point, I didn't want to take on any new diabetics. Exclusion were admissions to a SNF or a rehab facility, anybody in critical care, and then anybody not able to understand and that were not going to be self-managing, that they were going to have other caregivers managing their diabetes. So the basis was to go through, find diabetic patients that had poor control, which we used as a hemoglobin A1C of greater than 7.5, and provide a pre-education assessment using survival skill education based on the ADA recommendations, ask a structured interview based on those questions, get a baseline score, provide personalized education based on that assessment, and then 7 days after discharge call and administer the same questionnaire to understand their increase in education. And then we also followed their 30-day readmission rates. So received approval from both the university and from our facility. Did chart reviews for all patients. During this study, we had 73 patients admitted with a history of diabetes. Did chart reviews for inclusion and exclusion criteria, got consent from the patients. Again, did the pre-education assessment, provided education both on medications, diet. Survival skills also includes them understanding their A1C, what that means, how they can reduce A1C, how to take their medications, and then a post-discharge reassessment. So resources, the main resource was the time in going through and locating all of these patients, going through the charts for inclusion, exclusion, and then getting education materials for them. Had the diabetes coordinator from our larger facility. So the larger facility is a 500-bed level 1 trauma hospital, and that was supposed to be the basis of where this took place. I was switched to the sister facility, which was a 54-bed acute care hospital. And so the diabetes coordinator from the larger facility assisted with providing the education materials and helping get it some flow of information to that smaller facility. Risks were just potential disclosure of patient and private information. And then the benefits that patients received: education, and then the facility had the additional resources to where I was able to provide staff education as well as patient education and be able to improve the staff knowledge. So data collection and education was from January 14th to February 28th. Data was collected on a spreadsheet with the pre-education assessment and post-discharge assessment being scored and 30-day readmissions being tracked. So the outcomes is, obviously we would expect the post-education assessment scores to be higher than the pre, indicating a retention of knowledge. And then readmission rates as percentages, and then our process outcomes, the discharge summaries with medication reconciliation, follow-up appointments, and diabetic teaching documented in the electronic medical record were all as percentages. And our diabetes coordinator from that larger facility did create a survival skills checklist, which is a great 6-page, easy to read, low literacy level brochure for diabetic patients at that facility, which we were able to move over to our smaller facility, which really goes step by step on everything the patient needs. And we were able to get that written education for all of our diabetic patients. So I used a spreadsheet to group and sort data such as gender, age, race, and insurance. Averages were taken for the hemoglobin A1C, the pre-education assessment, post-discharge assessment, and compliance. And then I ran a paired t-test on the pre-education assessment versus the post-discharge assessment. And then percentages again for the compliance scores. So the results, the pre-education score, it was on a 0 to 15 scale. It was 15 questions worth 1 point apiece. Only had 4 patients that, out of the 73, there were 11 that applied in the inclusion criteria and only 4 consented. So of those 4, the average hemoglobin A1C of those 4 was 8.9. Their pre-education assessment score was 9.5. Post-education assessment was 13.25. On that data, that paired t-test was 0.035, which was statistically significant, but with such a small study, it's kind of hard to tell, but it does lead to clinical significance that these patients do need the education to be provided. Post-discharge compliance looked at, are you checking your blood sugars? How often are you checking your blood sugars? What medications are you taking and how are you taking your medications, and compared to the discharge summary? And all 4 were able to answer all 4 questions correctly based on their discharge summary. So that does show that discharge communication is finally getting to the patients that need it. Since the facility had never tracked readmission rates, this was our first chance for baseline. Only 1 of my 4 patients was readmitted, and it was a planned readmission. She had had a knee surgery and came back 2 weeks later to have the other knee surgery. So that wasn't really an appropriate look. I did look at all 73 diabetic patients that had the A1C of 7.5 or greater. And of those patients, the inpatient readmission rate was 12.33, which is actually very good compared to the national average of almost 20% for diabetic patients. And then a combination of inpatient and emergency room visits was 16.44. No discharge appointments were made for my group of patients, but the other caveat there is 3 of the patients already had discharge appointments prior to their admission. So they were already planning within the next month to see their providers. Physician discharge summaries with medication reconciliation specifically addressing their plan of care for diabetes was done 79.5% of the time. So some room for improvement, but the doctors overall are doing pretty good, at least in getting that part in the computer. One thing I was really surprised at is our nursing documentation for diabetes education was 45.2%. And I did a staff in service to try to increase the bedside nurses' knowledge, and the documentation actually dropped to 43%. So definitely some major room of where to go next is focusing on the bedside nurses. Facilitators, again, the diabetes coordinator from the larger facility, the quality coordinator, and then my primary preceptor, Dr. A.J. Stevens. He was at the larger facility but continued to follow at the sister facility. Our CNO at our facility and our director of nursing were great at helping me get through the approval process. The major barriers were the shortened period of time. The facility was not able to give me approval till January 14th, and we got implemented right away, but it was I was hoping for more than 6 weeks. It's hard to follow 30-day readmissions in a 6-week time period. And then the low census. We were expecting to be able to do this project at a 500-bed facility, decreasing to a 54-bed facility. The average census that in the med-surg, telemetry, and progressive care units was only 27 patients a day, with 5 of those being patients with diabetes. Major focus needs to be a focus on bedside nurse education. If the facilities are not willing to hire diabetic educators and want the bedside nurses to do it, we have to focus on giving those bedside nurses the resources to be able to do the education. And then continuing to follow readmission rates to see if that is an accurate picture. So looking at potential cost savings, one of the studies that we looked at said that inpatient diabetes education could reduce readmission rates by 34% and reduce length of stay by 2 days, which could lead to a savings of $5,000 per patient per hospital stay and could lead up to a $5 million annual savings. So again, some recommendations is bedside staff education and having unit champions that are extremely knowledgeable in diabetes so that the bedside nurses do feel like they have a resource that they can go to if there are questions that they don't understand. We currently don't have any affiliation with any outpatient diabetes self-management. I'm from Dallas, and 2 of the larger hospital systems do have self-management outpatient education. Our facility is not affiliated with either of those. So getting some of those affiliations, because Medicare will pay for self-management education, and so we need to be able to provide those opportunities for the patients. And then there are new recommendations for type 2 diabetics for discharge in changing up their medication, that if their A1C is less than 7, they should be going home on whatever they were doing prior. If their A1C is between 7 and 9%, they should be going home on a long-acting insulin plus whatever their prior oral medication was. And that long-acting should be 50% of whatever they were using daily in the hospital. And then if their A1C is greater than 9%, they should be going home on 80% of what their total daily dose was in long-acting insulin and following up every 2 weeks with an outpatient provider to get that regimen tightened up. So great study and discharge recommendations that I would love to be able to see what that could bring to the facility. So our facility has agreed to continue doing in-services with the bedside nursing staff, start getting unit champions trained in diabetic education. Right now I'm hoping to be able to move into one of those positions and move into a daytime. Right now on night shift it is hard to provide that diabetic education. So moving into a day shift position to where I can provide more of the education throughout the whole facility. And then we're going to continue tracking readmissions. We are working with the analytics team because right now I had to manually look at each patient, all 73 patients, to see if they had come back within the facility. So trying to get with the analytics team to see if they can run a report to track that a little easier. And then the 2019 ADA guidelines just came out, they are recommending that within 1 to 2 days of discharge, physicians go ahead and transition the patients to whatever they're going to be going home on. That way we can monitor their blood sugars on what their true outpatient recommendations are. And that'll be a lot of education for the hospitalists. So contributions to my personal goals, I'm hoping to go into a leadership and management position. And so being able to do a quality improvement project and get this going will definitely help get me there, hopefully. References. Approvals, went through the University of Arkansas IRB. Our Medical City IRB found it exempt, but I did have to get facility approval, and then they did approve for me to present today, which apparently is a big deal for them. So thank you to my committee, which is here, and then all of the professors throughout this program. It's been an awesome program. Any questions?
I don't so much have a question, but I just have you're telling us there are no positions for diabetic educators. I understand that in your system. I have a suggestion for you when you do have that leadership position. This would be as you mentioned, you wanted to continue doing QI projects. I think a policy project creating a position or positions based on the evidence and the trends that you see would be an excellent next step for you. Because it just doesn't make any sense, I just think.
It doesn't, and they have, I know 2 of the 3 systems in the Dallas area have eliminated the positions in the last 5 years.
Well, and we know that's probably because of cost, but you've got the evidence of how a position like that will pay for itself. I mean, I just,
in talking to our diabetes coordinator, she thinks those positions will come back once, like with the heart failure, pneumonia,
yes,
affects Medicare reimbursement.
Exactly. Yeah.
Once diabetes is lumped into that, then she feels that there will be a focus on education. But until then, unfortunately.
And I would say, even when you do the diabetes certification, become the diabetes educator, even working on an outpatient diabetes education program for patients that are discharged, that are newly diagnosed with diabetes is so important. I mean, we rely so heavily on the ones here locally that I can't imagine that those patients don't have access to that, because there's.
And it's amazing, they don't even provide, bedside nurses are even expected to do diabetes education for brand new diagnosis. And that's with everything else that we have to do as a bedside nurse.
Right.
Being able to provide that extensive of an education is not feasible to truly provide what they need.
No. And you really need that background as a certified diabetes educator to really truly be able to relay that information effectively to the patients.
Certainly more than 45 minutes worth, right?
Exactly. They're given a handout in 45 minutes, and that is all the brand new bedside nurse is given. Thank y'all.